anytime you're ready, we'll just delve right into that, do some questions and recommendations, and then go into Katie's didactic for the second half. So I can pull it up for you, and the floor is yours.
Great, thank you, Mitra. I just want to say that I picked a case to show my lack of knowledge, and I try to pick the cases that are the most embarrassing for myself so that I can learn the most where I know that I'm out of my depth. And this is an area that that I really feel like I feel like I did not deliver ideal care, and I'm making an example out of myself on purpose. I have learned the most that way, and because I know some of my spokes had talked to me and they said that they were afraid to present cases because they were afraid that that they would it would be too embarrassing. But I just want to like sort of go first and just make an example out of choosing a situation where we don't know how to do things in the ideal way, because this is really where the Echo really shines, is in helping us to learn in our weak areas. And this case is not something I could have solved, by the way, and done a better job with a textbook. It's going to really require the expert knowledge of the folks there at West Virginia University. So the patient I'm presenting is a young lady, 29 years old. The screening encounter date is wrong. She actually came to us on May the 20th, and she came to us by way of primary care within Cabin Creek as a referral. She's a Medicaid patient, white lady. So the main question for the case, and the area that I basically I don't think I did a very good job at, and that's where I'm hoping to get the help, is how can we improve buprenorphine induction and patient retention in heavy opioid users who do not want methadone or inpatient treatment. So it's going to be a case about a person who basically quit me because as I was trying to get her onto buprenorphine, she did not have a good experience but didn't want to do anything else either that maybe would have been more appropriate. So as I mentioned, she had come to, I'll start the assessment section. She came to our clinic after basically just reporting to the primary care doctor at Cabin Creek with the goal of finding our clinic. And she didn't really want anything primary care-wise. She just wanted help with discontinuing heroin and fentanyl, which she had been using multiple times per day since October 2019, although she had really a very long, much longer history of overall polysubstance use. It's really just been about 10 months overall that she really been heavily using opioids. She had actually already been rejected by the methadone clinic, according to her, due to she had only been using for 10 months, that wasn't long enough. I don't know the methadone clinic rules. I'm interested in hearing feedback on that and if that could be true or not. At our first visit, she came out and she said, yeah, I use heroin and fentanyl, prefer fentanyl. But really, when I say fentanyl, I mean carfentanil. I mainly use carfentanil. That's what my boyfriend gets usually. I only use heroin if that's all I can find. It doesn't do anything for me. I really didn't believe that much because actually I hadn't had a patient who described carfentanil use that they could get regularly. And I wouldn't expect someone to know the difference between fentanyl and carfentanil that's a user. Usually they can't tell the difference between heroin and fentanyl as users in my experience. Anyway, going back in time to her whole drug use history, she had started using at a very young age, 14, with alcohol and cannabis, which cannabis was the original drug of choice. Then she moved on to Adderall and Ritalin by the time she was, and as well as Xanax and Clonidine by age 16. But opioids weren't a thing. She got married, stayed sober a long time, then got divorced, then got with a I'm not sure, I may be inferring too much, but I think that she got back into substance use and opioids when she met this boyfriend that she's living with now. But I'm not sure if that's how she got restarted, but that's what happened roughly around October-ish 2019. She said that she thought that she was only being offered cocaine actually when she got started into fentanyl. So she also had alcohol use disorder on her electronic medical record and benzodiazepine use disorder on the record, which I was concerned about at the intake, but she said it had been at least a week. And the UDS did not show the benzos, it only showed OP. We did not send it off. So I don't know if it actually had fentanyl or carfentanil in it. I don't know. I don't think my drug screen even detects carfentanil. We also didn't send off, so we did not get ethyl glucuronide testing at intake. She, at the intake visit, this is on May 20th, she said she was in withdrawal initially, and she seemed to be in withdrawal. She was fidgety and uncomfortable appearing, but she told various stories to first the nurses, then to the care management, then me, and about when her last use was exactly. But I'm pretty sure she was lying to me when she told me that her, based on just context clues, I'm a former poker player. I'm pretty sure she was lying to me when she said that her last use was the night before, and that probably her description of actually using opioids the same day as, which she gave to the nurse previously, was more accurate. In any case, whenever I'm later on, I'll get to what I decided to do. She did not, or she does admit that she struggles to go even 12 hours without opioids. And so I'm just going to mention that what I ended up doing was just telling her just to go as long as she could before she tries the Suboxone. But and for completion, she had last used meth 2 months prior and crack cocaine 1 month prior at intake. So the primary care doctor seemed to recognize from her story before even sending to us that she may be better off to start with an inpatient setting, but she has zero interest in that, and the methadone clinic had already rejected. So Suboxone seemed like the choice. She had not tried Suboxone before, had no previous experience until I gave it to her, and she reported the reason she wanted outpatient care was so she could go back to work. But I think a lot of people just don't want inpatient care. They don't like to be locked up. They feel like they're locked up. That's going to be one of the questions for the WVU team, is like how you all help move them to the point that when inpatient is appropriate, that they choose to do it for themselves. She reported having losing 2 jobs because of addiction, and she stuck with wanting to get a job was the reason she couldn't go inpatient. She said her main reason for seeking treatment was she's tired of her life. She had no legal issues, no children, and as I mentioned before, she's unemployed, lives with her boyfriend, and Bailey informs me that they were going to lose their house. There were some financial issues emerging that led to the treatment. The boyfriend, however, was not interested in it at all in treatment, and he intended to continue to use, and she was going to continue to live with him. So I already mentioned the methadone clinic said she hadn't been using long enough at 10 months. At induction, I've already talked about this. Okay, a little bit. I mentioned that I advised her to start taking the Suboxone, just tiniest amount that you can take, and as long as you can wait after your last use of heroin. And I just sort of winked at the 11 p.m. yesterday, but I didn't make her take any medicine in office, and so she could just take it home and home induce. And that way, my hope was that she would not have a terrible induced withdrawal reaction. If the carfentanil story was true, or even just heroin, if you just give Suboxone right after heroin, regular heroin use. But And I gave her 6 days supply, and I was going to just put her into the weekly group as planned. That was the plan, but she didn't return back to the weekly group 6 days later. She said that she had a terrible, nauseating illness after her first dose, and she was afraid to take very much at all, although she had been continuing to take a little bit at a time. It was a little vague and unclear. It was all telehealth on this next follow-up visit, so I didn't really know exactly how much Suboxone she had left over, and she couldn't really describe it real clearly. But she did describe very vividly that she had a terrible reaction to Suboxone, and even when she continued to try to take it, even in small amounts, it would make her sick, and so she would end up then using carfentanil to try to deal with the induced withdrawal. And so she was basically saying that she was taking more carfentanil than Suboxone, and she honestly really didn't plan on returning, but thanks to my outreach efforts, or I should say Bailey's outreach efforts, who's here and has really tried to keep her in the program. She was willing to come back and see me even like a day later than had been originally planned. One of the big complaints she had was that she could not sleep after taking Suboxone. And so she reported taking Xanax herself. She was on telehealth, so I don't even have a UDS to show that benzo. But even at best, even after like the really bad reaction no longer was happening with just small amounts of Suboxone taken very long after carfentanil. She reported that Suboxone just made her aggressive, irritable, angry, did nothing for withdrawal, did nothing for cravings, and so she just hated it and she didn't see the point. She just wanted to switch to methadone. So it says here that she took a Cordystrip Q6 hours along with a little bit of heroin. That was certainly at one of the days, but later on, I actually had her taking just even less. I tried to just talk her into taking like a milligram or less per day because of something called the Bernese method that I've read about, some microdosing that a lot of times do inpatient, very, very tiny amounts of buprenorphine to try to get people switched off in this situation. But that's usually done in an inpatient setting. And another question for you all to think about for the feedback is, how accurate is cutting up a buprenorphine strip into tiny little pieces? Is maybe one piece got a whole bunch of buprenorphine in it and the next piece have none. I think that it's not evenly distributed. And so I think that might have undermined that approach that I was trying to take. So anyway, after she told us about the benzo, we did give up on the idea of putting her into standard protocol. When I moved her to come back every 2 days. I wasn't going to give her any medicine because I thought she hadn't been taking that much, but she really wanted me to give her more. So I guess she had taken it. She wasn't in office. So I agreed to give her 2 more days of medication. It was actually at 12 milligrams. And see her back in 2 days, which also didn't happen. I did add clonidine also to try to help with the sleep and hopefully reduce her temptation to use Xanax with it. And of course, warned her about the risks of taking Xanax with Suboxone. So let's see, we go down where it says she returned one last time 4 days later after I gave her that 2 days more of Suboxone, and this was on June the 1st. She was still having the anger and irritability every time she tried even the tiniest amounts of Suboxone. She pretty much said she intended to go to methadone. I tried to encourage her by having several of the other patients on the IOP call tell her about their experiences, because some of them also had been on and off methadone. All of them actually were very supportive of her not switching. They all encouraged her. I really didn't even have to encourage the other patients to do it. They're all like, well, if you give up on Suboxone now and go to methadone, it's going to be harder later. But she seemed to be inspired to return, but she didn't return. She hasn't answered our call since, so we haven't really had opportunity to follow up. Fortunately, we did give her the Help for West Virginia hotline number. It's in the Narcan scripts all very early on in her care, so we didn't have that issue that always seems to come up with people self-discharge without being able to give them proper discharge planning. So that's pretty much the whole case. I guess if I try to open it up for the feedback from the experts, what would you do differently with Suboxone dosing and encouragement? How would you get them to go inpatient if you thought that's what they needed? Maybe they just should have just pushed harder for methadone instead of inpatient. And what do you think about this cutting up of Suboxone films into little pieces? Is that all just madness with the Bernese method as an outpatient?
That was excellent. Thank you so much, Dr. Morrison. So we'll open it up for any of the hub members with any further questions and recommendations.
Well, first, Dr. Morrison, I want to say I am so grateful for you presenting a case. I appreciate you modeling for your spokes that presenting cases that we're not familiar with or sort of uncomfortable with what's happened. That's the whole point of ECHO. And while I don't want to tell you, I don't want to tell you how to feel, you certainly don't deserve to feel any embarrassment. That's the whole point of this. And I'm always so grateful when you're willing to bring cases up to show folks like this is what happens when we get stuck, because every single one of us gets stuck. So thank you.
Yeah, Ryan, to address some of your questions, first of all, good job. That's amazing. You really tried hard to engage her, and you also offered her different treatment options. For me, I always think it's best to let the patient weigh in heavily and the direction they want to take, just because there's more buy-in from that rather than me forcing them to do something. So I think you did the right thing by trying to meet her wish to do outpatient as opposed to inpatient, even though clinically speaking, inpatient might have been better for her overall. But we have to support our patients in their choices. So the first thing you mentioned is that most people don't know what carfentanil is. That's true, unless it's a dealer. So more than likely, her boyfriend is dealing, or he's either the first degree or the second degree dealer. And so that's how she knows. It is difficult to treat people with who are on carfentanil, because it's like, I think 5,000 more powerful for morphine and 10,000, you know what I mean? It's 100 times more than heroin for sure, okay? So we are all still learning about carfentanil under adequate doses. She sounds as if she went into withdrawal, even on the Suboxone, which was expected for her, yeah? And what we usually do in an inpatient setting, which is give more Suboxone, right? To kick out the withdrawal and just keep going up. But for her, she wasn't able to do that. But my concern for her is that she's probably not only withdrawing from the opioids, but also from benzodiazepine, because she said she couldn't sleep and then she needed the Xanax. So I'd be very worried about offering her further treatment as an outpatient. She is someone who I would say, hey, we tried it your way. For safety, I think it's better if you be treated inpatient, because not only does she have a problem with benzos probably, but she also sounds like she has an unstable mood, and you'd be worried about an underlying serious mental illness there, like bipolar 1 or 2, or just severe depression.
So at your clinic, Dr. Bowe, would you would have taken away the outpatient option after the first benzo use because of the concern that it maybe indicate severe benzo withdrawal risk?
I would have, what I usually do patients like that, I tell them, okay, how long are you willing to try this outpatient to see if it'll be successful? And then they let them pick a time, whether a week or 2 weeks. Most people don't say more than that. And then we say, okay, so how would you know when this has failed? And then let them come up with their own idea of how they will know if it failed. And then when they fail, because carfentanil is a serious drug, then you just remind them of what they said and then move towards inpatient. So I usually do it more that way. Let them set their limits, and then as they don't reach their limit or their goal, then you introduce the next step.
Thank you.
Yeah, I want to say, thank you very much. First, Ryan, this is a very good case. We're all learning something from this. And actually, if I were you, I would do exactly the same thing. I would try to, try to at least motivate this patient to stay in treatment. So two things, two questions I can answer here. I mean, from my experience. The first is talking about a methadone clinic. It's kind of silly. A lot of methadone clinics, they require people to have 12 months, like a 1 year physical dependence on opioids. Then how can we know it's 1 year? So it's, and that I don't know. I mean, nowadays, the treatment is kind of very different. I'm not sure whether it's a federal requirement. Maybe Dr. Hirschler or Dr. Fuller may be able to answer you that question, because I don't think it's appropriate to to refuse patient if that person is a polysubstance user and is using carfentanil, and this person is definitely a very high risk, and a methadone maintenance is indicated. So I don't know what I don't know why that they refused her. So it's kind of very silly. But the second is that apparently I believe this is precipitated withdrawal, and she was not feeling well, most likely because she was using. She used Suboxone too early. Very likely, or could be the combination withdrawal from something else. So. I think in this case, I'm not sure whether it's kind of practical for you to do the induction in your office. You can watch her to take like 2 milligram. That's what they used to recommend. I mean, we don't do that anymore because everybody has experience using Suboxone from off street or from somewhere else. So, practically speaking, it's still doable here in Morgantown if we can get the medicine from Medical Center Pharmacy, which is just across the road. You can get it. So, but I don't know how possible you can do it over there. But otherwise, this patient, I would I totally agree with Dina. And in this case, but because of polysubstance use, I would recommend inpatient treatment. That would be much easier for us to watch her to induction as well. But it's just if she doesn't want to do it, then it's very hard for you to keep patient in that kind of program. Anyways, you cannot just force her to receive inpatient treatment. So I guess I would do exactly the same thing as you did. Yeah.
I was just going to add about the methadone. It's been 20 years since I was involved in a methadone program, but there were regulations, federal regulations, about a year of use before someone could be admitted to maintenance treatment with methadone. And that was before the era of carfentanil, where that kind of puts into question how reasonable that is to expect that somebody's going to be using that kind of a powerful opiate for a year and survive it and get into a methadone program. I think they need to rethink that regulation. One thing I was going to say, I when I work with the pain clinic and treat people who've been using opiates for pain and mismanaging them and switching them to Suboxone, I will use like a sliver of Suboxone in somebody who's been on a long-acting opiate, and instruct them about being in withdrawal, and then recommend they use just a sliver to see if it precipitates withdrawal or if they need to wait longer. And so that seems to work for me. But this is such a potent opiate. The level of opiate that she lives at using carfentanil is going to precipitate withdrawal, even in a significant amount of opiate medication for maintenance treatment. So you're in a position where she's going to require large amounts of Suboxone if she's been using carfentanil. And I used to induce people in my office when I was in Maryland, and we would give them up to 8 milligrams the first day and 16 milligrams the second day and 24 the third day. So you could really escalate the dose. But there's a lot of distress, with being in withdrawal through that period. So it requires some motivational interviewing and really trying to capture this patient and say, look, this is going to be difficult, but the end result is a stable life and not putting yourself at such terrible risk of overdosing, and try to live a healthy life. So I don't have experience treating carfentanil withdrawal as far as I know. We don't test for it. I've never seen a result that showed positive for carfentanil, so I don't know if our toxicology screens are showing that. But I think it's a tricky matter.
Awesome. Thank you all so much. Were there any other questions or comments for Dr. Morrison about his case?
Dr.
Yeah,
Morrison, you asked a great question about the strips. I feel like we have enough people who tell us that they cut them up regularly, and we don't really hear feedback from them that that's not helpful. Now, those are for people that are usually cutting up in quarters. So if she was cutting it up in sort of tiny amounts, I've not heard feedback from patients that they feel like that's causing them any problems. Dr. Bowe, I don't know if you were gonna speak to that maybe.
Yeah, it was. So if you hold up this strip for Suboxone versus the strip for buprenorphine, the distribution is different. So some people, depending on their supply, it's not adequately distributed. So with Suboxone, the brand name, you good. But if you're going for the generics, you're not sure. We're not sure what it looks like, and I think that differs between different manufacturers.
Another comment I want to make is that, on DDU, sometimes we have those readmissions all the time. Patients just cannot really do Suboxone because they cannot follow our code rules, policies, and they keep violating all the rules, and they cannot come. And they come back to a DDU again and again for detox, but then we schedule them to Suboxone clinic. They just never showed up. So in this kind of case, a lot of times, they do need harm reduction. There's no doubt. So sometimes we do refer them to methadone clinic, and we just feel like a Suboxone clinic office management is not good enough. So we have several patients like that, and they do better. And of course, they still struggle, but some people do like methadone better. So, and it may be more appropriate for methadone clinic daily dosing. So in Medmark, they also have Suboxone daily dosing as well for patients who kind of, they just they inconsistently follow up. Yeah.
Phil, was there something you wanted to comment on as well?
Yeah, I was just going to say that, not being able to speak obviously to the medication itself, but more to addressing kind of motivation for change is kind of thinking about what Dr. Hirsch was saying, is implementing a lot of motivational interviewing, continuing to assess for the safety needs of the patient, which is what you guys did by offering, the 24/7 helplines and the prescriptions of Narcan. But we can only do so much if there's any concern that the person that they're living with is the dealer, the supplier. We can unfortunately force them to completely change their environment, just continuing to meet them where they're at, especially if they are, continuously using carfentanil or just, fentanyl or heroin in general. But then you add in the Xanax concerns with that too. And, when we're talking with folks about the importance of entering detox or entering a 28-day program, sometimes we can use the clinic as motivation for that. If they've continued to really struggle at outpatient care, we can say, in order to come back into clinic, we are highly recommending that you complete a 28-day program, or you at least complete inpatient detox. So we can use that to our benefit as well.
Yeah, that makes a good point. So basically, not everybody is suitable for outpatient MAT, and so it's just like those patients I mentioned. So it's kind of of course. ASM does not like a program-driven or we're talking about a program-driven treatment. So you have to finish this program in order for you to do the next program, or you have to finish this level in order for you to do next level. But actually, I think nowadays there are patients who are really not really motivated, and then they just like Phil said, for her partner. That's definitely an influence. So how can we manage her with that kind of a living dynamics, and then how in outpatient setting, then how can we motivate her more? I guess it's very hard. And Katie knows, and we have a patient who lives with his uncle, and he could not move out of the house, and he has been struggling. He has been in our co-clinic for a long time, and he kept relapsing, and he did well for a while, but then just because of his uncle, who has been giving him drugs, methamphetamine, all different kinds of things, has been a supplier of all different kinds of drugs because of living together with his uncle, and he I don't know what else can really help him. I guess Suboxone is keeping keeping him alive. But in the meantime, I guess that's pretty much the maximum we can do. I think moving out of the house, changing his living situation probably is very important. It's more important than the medicine itself. Yeah.
So the question I would like to ask them, if they're at best in contemplation stage of change, and that's being a little generous based off of the clinical criteria, asking them then what would preparation stage look like for them? Or, that sounds like to me like they're more so in pre-contemplation than what would even contemplation stage look like. And then it's using what Adina had said, and it's kind of getting them to formulate their own goals. And then at that point, we're able to assess, okay, so what can we do to help you get to that point in your life?
Perfect. Thank you all so much. Before we turn things over to the didactic portion, were there any other comments, questions about Dr. Morrison's case?
Mitra, this is Jennifer. I have what feels like a really basic question, but I just want to make sure I understand the medication dosing. And Dr. Morrison or anybody could answer this. So the purpose of dividing a low dose, like even Dr. Hirschler said he might start with 8, but the purpose of dividing that would be to avoid a precipitated withdrawal in her. Is that correct? And I guess the second question is, would it be better to, somebody mentioned watching her in the office until you're certain she's in withdrawal?
Well, in her case, it is because it's induction phase. Basically, we're initiating Suboxone dose. So you always want to go, start low, go slow. This is because the problem is the precipitating withdrawal, and because Suboxone is knock off all this 4 agonists. So that's the problem. And the patient usually they can they haven't waited long enough to start the medicine. Then they might that first experience is kind of, if the first experience is bad, then that kind of discourages them from in the future to continue the medicine. So I usually recommend them on DDU. So of course we check the cows and we make sure the scores are pretty high enough in order for us to start medicine. Then we have pretty objective sign. But in outpatient setting, when patient has medicine, then it's hard. It's very hard for us to control. So they may, just because of psychological reason, because of anxiety, then they start taking the medicine. Then they feel bad.
The other thing unique about carfentanil is the half-life is like 5 to 6 hours, and it's staying in the system for 12 hours or more, and so it's going to take a while to precipitate withdrawal in somebody who's using that medicine, that opiate. So it's fentanyl is very short acting, and heroin is not that long acting. So it's a different kind of a situation.
Yeah, but because another thing is they mix. You never know what they really use, and sometimes they use something kind of could be a little bit long acting as well. So they didn't. It's very hard to say. Another thing is, buprenorphine itself, the half life is 20 to 40 hours. So it's designed to be taken once a day. That'd be good enough for opioid maintenance purpose. But in our clinic, 500 patients, we still. So many patients they have been. They've been sober for such a long time, but some people still choose to take multiple times a day. They split the dose. Besides pain control, it's better. I think psychologically, some people may just want to take like twice a day. I don't know pharmacologically how we can explain that. So.
Thank you.
I would add, just from our experience too, we had a couple instances with precipitated withdrawal at intake, and it was primarily due to patients not telling us that they were taking methadone. And since this case is a little bit crosses the methadone line there with some of her story, we actually had to switch the instant dip tests that we were doing at intake to make sure it included a methadone panel on it, because that was a culprit. I haven't had any experience with carfentanil, but methadone was a big one for us that was causing that bad first experience that Dr. Zhang was talking about. So.
Thank you for sharing that. And thank you, Jen, for the question. Certainly not basic at all. We welcome all questions, so we appreciate it. So before we move to the didactic, Dr. Morrison, did that answer a lot of things for you? Are we okay to move on?
Yep, I'm good. Thank you all for your great, valuable input.
Perfect, and thank you for the case. We really appreciate it. All right, Katie, so I will pull up your didactic and I'll turn things over to you.
Thank you so much. Do you flip through the slides or do I do that?
I can give you remote control if you prefer that, and if you prefer me just advancing it for you, I can certainly do that as well.
It's probably better if you do that, otherwise who knows where I will take us. Thank you so much.
No problem.
So I'm going to talk about mutual support groups today. Mutual support groups are groups of peers who share a common problem, something like addiction, and they offer support to one another. There's a wide range of those kinds of groups that take place today. That format originally existed with AA, but branched out to other specific populations with specific needs, and there's some varied in the format. Next slide, please. Thank you so much. So historically, AA is thought to have been founded on June 10th, 1935. Shortly before this day, Dr. Robert Bob Smith had met with William Bill Wilson. They were recommended by friends to meet with each other as Bill was recently sober and trying to navigate his own sobriety, and Dr. Bob was still actively drinking. It was during this meeting that they realized the power of sharing with each other and therefore helping each other out. So the self-help philosophy of AA was born from this moment, and then days later on June 10th, Dr. Bob took his last drink. AA took a while to get off and running. I believe after the first 3 years, there were still only a couple of active AA meetings taking place. Within the 4th year, however, membership started to grow, and so the early founders of the meeting decided to put together a book, a compilation of their stories, along with a blueprint of the AA program. That book is called Alcoholics Anonymous, but it's often referred to as the Big Book. By the mid-1940s, a number of African Americans with alcohol use disorder had also begun attending meetings, and Jim S., a physician, was considered the originator of AA's first Black group. I think his story is referred to in the Big Book. And then the book AA for the Black and African American Alcoholic has also been added to AA's library. I don't actually know the copyright date for that. Then in 1953, a new self-help group was founded that followed the AA model and was called Narcotics Anonymous. The quote here is taken specifically from their Narcotics Anonymous book, which is their version of the Big Book. So we follow the same path with only a single exception. Our identification as addicts is all-inclusive in respect to any mood-changing, mind-altering substance. Alcoholism is too limited a term for us. Our problem is not a specific substance, it's a disease called addiction. AA and NA aren't technically affiliated with each other, but they often collaborate and cooperate with each other. There are a number of publications that you can check out that talk about the diversity movements that have taken place within the 12-step programs. It is important to note that the lack of diversity sometimes comes up among criticisms of meetings, which we'll talk about in a little bit. Next. Oh, by the way, those are my goats. Anytime I give a presentation, I always try to get my farm animals in there. So that is Pip and Squeak. They're each other's support system. Next slide, please. So as I mentioned, other support groups have taken that AA self-help structure and created similar models. Of course, bigger cities tend to house a more variety of meetings. So examples of that would include, so we already talked about AA and NA. Some of the larger cities, there are self-help meetings for specific substances like Cocaine Anonymous or Heroin Anonymous, and that can be pretty powerful for members. Some of the process addictions or behavioral addictions, something like Gamblers Anonymous, they've also branched out and created their own specific support group meetings. Rational recovery and smart recovery meetings were created in an attempt to utilize cognitive behavioral psychology to address the needs of folks with substance use disorder. The one difference with those is to lead those meetings, the leaders have to actually attend a training, but again, they don't necessarily need a degree for it. SOS stands for Secular Organizations for Sobriety, or Save Ourselves. That runs on the mutual support group model, but it doesn't view spirituality or surrendering to a higher power as being a necessity to maintain abstinence. Then things like Al-Anon, Nar-Anon, and Alateen, those meetings were created to address the needs of the family members of the folks with substance use disorder. As we know, the addiction rarely just affects the person with the addiction, right? It affects also the people around him or her. So those meetings give family members a chance to open up about their experiences, learn how to deal with the stress of living with somebody with a substance use disorder, recognize their own enabling behaviors or their struggles with boundaries, and help them bring back the focus to their own lives. Next slide, please. Thanks so much. At the core of AA are the 12 steps. Now, these steps are not required for members to complete, but simply they're just suggestions on how to achieve lasting recovery. If members want to go through the steps, they're encouraged to do so with the support and guidance of a sponsor. Sponsor somebody who's been in the program for a while themselves, they have a good chunk of sobriety under their belt, and they've worked through the steps themselves. Those 12 steps typically, well, they fall into 3 groups. Steps 1 and to 3 really focus on helping the individual make the tough decision to confront their social stigma associated with addiction, to accept that the disease affects the individual and that the individual is powerless over it. Steps 4 to 9 are what we call the change-oriented steps. These help the individual identify, confront, and then overcome any of their struggles that are thought to support their addiction. These steps are designed to help the individual process through any kind of guilt that often arises and then to let it go. Steps 10 to 12 encourage the patient to continue to build on the foundation established in the earlier steps. If we looked at the stages of change model that Phil mentioned earlier, these would be considered or associated with the maintenance stage. And then in terms of the higher power mentioned in these steps, the only requirement for higher power is that this indeed be something greater than the person. Next slide, please. Thanks so much. Oh, these are, I need to fix the slide. If you can just pull these up along the way as I'm talking about them, or you can pull them up all now, whatever's good for you. We're gonna talk about the pros and the cons of 12-step programs. So for pros, they're open to anybody that needs them. Becoming a member of a 12-step program is available to anyone. And for anybody, if, as we know from when we're working with folks with substance use disorder, sometimes the best time to get them help or resources is right in the moment. So imagine if you had somebody who right in the moment said, okay, I'm willing to admit that maybe I have a problem and I should have to go to an AA meeting, or I think I should go to an AA meeting. And we said, oh, okay, you just need to fill out this application and we'll get back to you in 6 to 8 weeks. That's terrible, right? Folks with substance use disorder need help right now. And so meeting and recovery help is available to them right now. The meetings are highly accessible and available everywhere. These days, even some of the more rural parts of West Virginia have at least 1 or 2 meetings a week that take place, so you can always find them. They're also online, which we'll talk about in a little bit. So for folks that have location issues, transportation issues, maybe social anxiety issues, they can go to an online meeting and attend that way. The program is free. There's no dues to pay. There's no admission fees that you have to pay in order to get into a meeting. Each chapter is self-funded, so members are welcome to donate, but they certainly don't have to. It is a flexible program in that you can work the program around your life. So maybe sometimes you go to morning meetings and then sometimes you go to afternoon meetings. Maybe for some folks they work the step and for some folks they don't. It's flexible in a way that, for example, our coach clinic isn't. By definition, a self-help group is self-governing, and that can be incredibly comforting to folks, particularly early in recovery, who are maybe dealing with shame and feeling like I'm all alone, I'm the only person that's gone through with this. It can be such a meaningful experience to walk into a room and hear other people share details of literally what you've been through yourself. And so, of course, along with the pros, there's cons to the 12-step programs. Not everybody digs the spiritual emphasis of the group, and this often gets confused with there being a religious component to the program. While the program does have a flexible aspect to it, some people actually view the program as rigid. For example, our medication-assisted treatment patients, they sometimes run into this. Our patients tell us that they go to meetings where the people will tell them, if you're on Suboxone, you can't speak in this meeting, or if you're on Suboxone, you're not really sober. And so while that's not a true principle of the 12-step meeting, the folks that are running those meetings can potentially communicate that rigidity. It's funny, we want to encourage people to go to meetings for support, but we also have to be weary of people relying on meetings to a codependency level, a compulsiveness level. It can become a bit of a compulsion if somebody feels like, well, if I don't go to a meeting, then I'm absolutely going to crumble all on my own. Depending on where you're attending meetings, there might be a lack of diversity in the meetings, or there may just not be an option for them to attend many or any meetings that honor their specific needs. For example, in Morgantown, there's only a few gender-specific meetings, and there aren't any meetings currently that I'm aware of specifically for persons of color, and there's very little of those meetings online as well. And finally, for members, for our patients that have suffered certain traumas, these meetings can potentially be a big trigger. You've got crowds of people there. You've got folks who are struggling with their own emotion regulation. You've got people who might be sharing raw details of their own trauma. And that, again, could be a really big trigger for folks. For some of the women that I've worked with, they've talked about being sexually harassed at meetings. And so for them, they want to really only go to women-specific meetings. And as I mentioned, based on where you live, that may or may not be an option. Next slide, please. Thank you so much. These will just pop up along the way. So now more than ever, our reliance on technology to aid our folks in recovery is significant. There's nothing like a pandemic to prove that while technology used to be seen as a privilege, it is now a need to access life-saving resources. Most of the role that technology has played in the recovery field is good, but of course there's some issues with it. There are websites for various types of mutual support group meetings online where you can locate your community meetings, you can learn about other resources and various tools to help you in your recovery. Some self-help support groups have a presence on social media, which can be a great way to get people involved, particularly our younger population. There are several different recovery-oriented apps. So some of the bigger groups like AA, Smart Recovery, and Celebrate Recovery, they have their own applications for your phone or tablet. A lot of my patients use SoberTool, which is a way that they keep track of their own days. Online meetings are really helpful for our folks in rural parts of the state that either don't have enough meetings near them, or they can't get to them transportation issues, or if they're living during a pandemic and can't get to any meetings in person, we've got those options. A lot of my patients use intherooms.com for this. So let's talk about the pros and cons of technology in recovery. So for pros, it's a great way to access resources for recovery, including local resources. It's a great way to access immediate support by finding somebody online who's available to talk right then and there. It can be a way to address our loneliness. Maybe I can use technology either to connect with local people with substance use disorder and meet up with them in a meeting, or I can use it to chat online with people who understand what I'm going through. And those connections I make online, they might help me in the process of making sober connections face-to-face as well. And these days, technology is always around. I generally, unfortunately or unfortunately, always have this thing with me, right? We always have our smartphones on us. And so if I'm getting ready to face a trigger, I can just pull out my phone and text my sponsor, or get online and chat with somebody else, or get on my app and read through some of the coping skills. On the con side, in this day and age, we have to admit there's a lack of emotional safety online. How do I know that what I'm sharing isn't going to be judged by or mocked by you? I may be faced with people expressing hurtful comments or abusive comments online. And so much of what we say and do online lasts forever, and it could be used against us in some way. So I think we all struggle with that little bit of lack of privacy. There's definitely a culture that glorifies substance use online. Morgantown is unfortunately a great example of that. If you're on Facebook on a home football game day up here, you're going to see countless pictures of people drinking beer while standing under a pop-up tent at 11 o'clock in the morning. We tell ourselves it's okay as long as they're wearing blue and gold, but for somebody in recovery, that's something that's hard to be faced with day in and day out. And so either it's going to be an initial trigger to drink, can also lead to that struggle, that fear of missing out. Constantly having technology available to us also can lead us to compulsive use. So if I'm newly sober and I'm dealing with letting go of my compulsive using habits, it's possible I'm going to replace it with compulsive technology use. And then, as always, for all the really helpful information out there, there is a lot of misinformation. Dr. Google gives out a lot of free but inaccurate medical advice. And then last slide. So the biggest point that I really want to drive home when I talk about mutual support groups is if you have not been to a 12-step meeting, go, and please go to several. Get a sense of what the experience is like. what it's like walking into the rooms for the first time, what it's like to find a seat among the crowd, what it's like to hear the people's story, see how the meeting is run, what it's like when a new person speaks up or asks a question, what it's like when an old timer speaks up or asks a question. Not only is this going to enhance your empathy for your patients, but it's also going to give you a chance to give them firsthand knowledge of what the experience is like. Because if you recommend a patient to go to a meeting and they ask you what it's like and you say you've never been, that's going to potentially decrease the chances that they're going to go themselves. Because it's like, well, if Katie's not going to go, if Katie's not been to them, why should I have to go? I will say it seems to mean a lot to the outsiders when you show up to a meeting because you want to learn about it. I teach an addictions course for the university, and one of the assignments that I give the students is for them to go to an AA meeting or any meeting in person. And typically the bulk of them talk about the anxiety that they fear going into the meeting. They're afraid they're going to be judged or looked down on for infiltrating this meeting. And probably 95% of them they come back and they talk about this positive experience where folks came up to them afterwards and said, thank you so much for coming and learning about this experience. Thank you so much for observing what we do in here so you can share with your future patients. They really appreciate that folks are there because they want to learn. So if you've not been to meetings before, please go to several. And that's my last slide, I think.
Thank you so much, Katie. That was
Yeah.
excellent. And may I first say, I love the pictures of your goats. They're so cute. I love goats.
I try to, it's either a goat or a pig pictures in there somewhere.
Oh yeah, I love it. Thank you so much. So I wanted to open it up for everyone. Were there any questions, comments for Katie?
I have a common kind of question. You brought up technology, and it's interesting to me how rapidly and to what extent technology is advanced. And yet we're using 1930s technology for 12-step recovery. And so why is it that mutual support groups and even psychotherapy to some degree isn't accelerating in the advancement at the same rate that technology does? And what can we do to make that happen?
That is a fantastic question that I do not have an answer to. Anybody in the group have thoughts on that?
I think from a therapy perspective, you look at something as old as psychoanalysis. While it's old, and the class I'm teaching in the MSW program, they had to learn about psychoanalysis for this past week, and their biggest concern was, well, this was created a long time ago. What benefit does it have now? A lot. It still has a lot. A lot of the newer modalities like internal family systems therapy, even to some extent EMDR, cognitive processing therapy looks over to CBT. So there's a lot of things in which the older modalities are being crossed in with the newer modalities. And an old clinical supervisor of mine would probably have my head if he heard me compare psychoanalysis to some of the newer models, but that's okay.
Oh, I know who you're talking about.
But, and so there is kind of that cross section between at least the therapy models. And I believe that my guess would be that AA and NA kind of have that same mentality. If it's been working, then why change it?
Mm-hmm. Mm-hmm.
But on the other hand, we are using new technologies in addiction treatment. For example, we're trying to do a pilot study on contingency management app. So there's an app, it's an app on clinical trial. So basically, we're going to recruit patients. We're going to use contingency management, which is embedded in the side app, so patient can get a reward from participating, from finishing the online modules of CBT or different kinds of things. So I'm not sure for 12-step meetings and but at least they're using new technologies, because now they're doing online meetings. They have online chat rooms. Maybe down the road in the future they have like a more like kind of meeting oriented software that can make it happen, like using Zoom for Zoom is designed for meetings, but Zoom is not designed for patient interview, right? Mm-hmm. But Zoom, so we're talking about 12-step meetings and meetings, so maybe down the road there are going to be some new tools that can be used. But I want to ask a question. I want to ask Katie, because Katie and we always sit together with patients. So on DDU I heard a lot of patients. I mean, in our in our co-clinic, outpatient setting, we don't really hear this a lot because we require them to do meetings. I know it's hard to require people to do meetings and
Yep.
for them to really benefit. I guess it's always debatable thing, but yeah, majority of patients, they do feel it's beneficial, and they're really, in later stage of recovery. We have these patients who are kind of 3 years, 5 years recovery and better. Then they're looking backwards. They said, "Oh yes, whatever you guys required us to do." And in the beginning, everybody agreed it was very helpful. So that's for sure. But on DDU, I always heard people say, "Doc, I hate meetings. Those meetings don't work for me. They make me want to drink. They make me want to use." So I don't know. I mean, Katie, do you want to share some experience, like when patients talk like that? Then what's the best way? What's the best approach from your stand?
Dr. Zhang, great question. You're right. Dr. Zhang and I share a lot. I have the benefit of sharing a lot of groups with him, and they're anywhere from weekly groups to monthly groups. So we will ask the monthly groups just to kind of reflect from time to time on, what's helped them get to that point. And almost always they will say things like, "Man, I didn't want to go to meetings when I first started. And now I see the benefit. Now that I've got several years, I can look back and understand why that structure and why that accountability was so helpful." And so when I get that kind of pushback, maybe for our folks in early recovery in our weekly groups, often I want to explore if it's in a group setting or individual setting, I want to explore a little bit more what's behind that, what's behind their resistance to want to go. And there's often some fear associated. Maybe they had a negative experience when they went to a meeting before, for all the pros of meetings, for example, the fact that they are self-governing, there also isn't 12-step police out there to make sure that every meeting goes appropriately and that folks aren't communicated to inappropriately before or after meetings. So maybe something happened and I can kind of help them walk through that experience. Maybe it's about recommending different meetings. That's one of the things I love about Morgantown today versus, when I think of when I started Chestnut Ridge 10 years ago, there's so many more different styles of meetings. There isn't just AA and NA. We've got smart recovery meetings. There's celebrate recovery meetings. There's a Buddhist recovery meeting. There's so many different opportunities to find a mutual support group that isn't just a classic AA. So sometimes it's about maybe educating them on different experiences. I also let them know I'm only asking them to, so for our clinic, folks are asked to go to 4 mutual support group meetings a week. I'm only asking them to do that for 4 hours. So if that's not the thing that's gonna work for their recovery, that's okay. We've got multiple hours throughout the week that we can look for other resources. So in addition to going to the meetings, I'm gonna ask them to go to, what else do they want to do? Do they want to go to church? Do they want to volunteer? Do they want to start their own meetings with friends? That's something different. If there's a resistance there, I'm not gonna try to convince them that, no, you need to go and you need to like it. Let's figure out something else that works for them while they still go to my 4 meetings. Anybody else, Phil, or anybody else, any additional comments on what's helped you with encouraging your patients to try out these meetings?
I think it's exactly what you said. It's trying to get them to for us to see where they're struggling with participating in meetings, and then it's reminding them to go to multiple meetings.
Yeah.
Through COVID, I've encouraged them to participate in lots of meetings across the country and outside of, outside of the U.S. even, just based on the fact that the nastuff.com website, they can attend meetings all the way in Bangladesh or the Philippines or different places like that. And then for these 24-hour meetings, even encourage them to stick around and have conversations in Washington State on what their perceptions of medication-assisted treatment are, and then what can we do to bring that mentality maybe back to Morgantown or West Virginia.
Yeah, totally. That's a great addition thought, Phil. Thank you.
Awesome. Thank you all so much. Any final thoughts or comments, questions? We are unfortunately at the end of our session, but if there are further questions, we can stick around for a few minutes if you guys would like. All right, well, feel free to email me any questions or comments if you do think of them after the fact, as always. Just one quick announcement. Our next session will be on June 22nd, and Laura Lander and Emily Chilko, I hope I'm not mispronouncing that, will be giving our didactic on teletherapy for OUD. So keep an eye out for that. I'll be sending out reminders and everything. And thank you so much, Katie, for the didactic, and thank you so much, Dr. Morrison, for the case. We encourage you all to keep submitting cases. We love them. And thank you all so much. We'll see you guys next time.
Thank you.
Thank you. Bye.